Okay. Hello, good morning to all. Hello. Now, can you hear me? Okay, I am Dr. Ankur. I am presenting the today's anesthesia topic, intravenous anesthetic induction agents. Okay. What are the IV induction drugs? These are the drugs when given intravenously in an appropriate dose, they cause rapid loss of consciousness. Rapid means often described as occurring within 1 hour brain circulation time. The time taken for the drug to travel from the site of injection, which is the arm, to the brain, where they have their effect. Coming to history, the first IV induction agent was the hexobarbital, the first ultra short acting barbiturate, and it is the first successful IV anesthetic. And it is introduced by Wies in Germany in 1932. And after that, hyopental came introduced in 1935 by Lundy in Minnesota and Waters in Wisconsin. Hyopental, it is widely accepted because of lack of excitatory myoclonic movements seen with hexabarbital. After that, propofol came. It is launched in 1986 under the brand name of Diprivan. After that, ketamine came. It is first synthesized in 1962 by Calvin Stevens, and first human use was in 1969. And after that, methotrexate came, a shorter acting barbiturate with central nervous system stimulating properties. It came in 1956 for electroconvulsive therapy. Now, what are the uses of intravenous anesthetic agents? These are used for the induction and maintenance of anesthesia, as a sole anesthesia for short procedure, for intravenous infusion to maintain anesthesia for longer procedures. It is called the TIVA. TIVA is the total intravenous anesthesia, and to provide a sedation in place like ICU. And how does it happen? From induction to wake up, what happened to a bolus of IV induction drug? First, the bolus of IV induction agent enters the bloodstream. A percentage of drug is bound to plasma protein and rest is unbound. Protein binding depends on the lipid solubility and degree of ionization. The drug is carried in the venous blood to the right side of the heart, and drug reaches to the left side of the heart through pulmonary circulation, through systemic circulation. And high proportion of the initial bolus is delivered by the cerebral circulation, as majority of the cardiac output is delivered to the brain, liver, and kidney. After that, the drug then passes along a concentration gradient from the blood into the brain. The rate of this transfer is dependent on a number of factors like arterial concentration of the unbound free drug, lipid solubility of the drug, the degree of ionization, and the unbound lipid soluble unionized molecules cross the blood-brain barrier to test. After that, the drug starts exerting its effect once it penetrates the CNS tissue. Each drug acts at a specific receptor like GABA A receptor, NMDA receptor, and the drug then starts to diffuse into the other tissues that do not have such a rich blood supply like a skeletal muscle. This secondary tissue uptake causes the plasma concentration to fall, allowing drug to diffuse out of the CNS down the resulting reverse concentration gradient. And this initial redistribution leads to the rapid wake-up seen after a single dose of induction drug. And metabolism and plasma clearance have a much less important role following a single bolus, but are more important after the infusion of a drug. This diagram shows the drug distribution in various tissues against the following an IV bolus of thiopentol. Okay. And how is it different in the state of reduced cardiac output? Suppose a patient in shock, how does it differ from the normal patient? When cardiac output is reduced in shock or in elderly patient, the body compensates by diverting an increased proportion of the cardiac output to the cerebral circulation, as preservation of the cerebral blood flow in these situations is important. A greater proportion of any given drug will enter the cerebral circulation. As a result, the dose of induction drug must always be reduced. Since global cardiac output is decreased, the time taken for the induction drug to reach the blood-brain barrier exert and its effect is prolonged. The crux is if the patient has a low cardiac output, if patient is in shock, we should decrease the dose of these induction agents. Now coming to the what are the property of an ideal induction anesthetic agent? First is physical property. It should be water soluble and stable in solution. It should be stable on exposure to light. It has long shelf life, and there is no pain on intravenous injection. It is painful when injected into an artery. It should be non-irritant when injected subcutaneously. There should be low incidence of thermoflavitis. It should be cheaper. What are the pharmacokinetic property of ideal anesthetic agent? It should be rapid onset in 1 hour within circulation time, rapid redistribution to vessel rich tissues, rapid clearance and metabolism should be there, and there should not be no active metabolites. Pharmacodynamic property, there should be high therapeutic ratio of toxic dose to minimal effect dose should be high. There should be minimal cardiovascular and respiratory effect. There should be no histamine release or hypersensitivity reactions. There should be no emesis or vomiting. There should be no involuntary movements, no emergence nightmares, no hangover effect, no adrenocortical suppression, and safe to use in porphyria. Coming to classification, the commonest drug currently in the use can be classified according to their chemical structure and include first are barbiturates. Example are thiopentol, methoxytel, phenols like propofol, imidazoles like etomidate, phenylcyclidine like ketamine, and benzodiazepine like midazolam, diazepam, and lorazepam. They can also be classified based on the onset of their action, like rapidly acting within 1 arm brain circulation time, like thiopentone, propofol, etomidate, and slow acting, those that take longer than 1 arm brain circulation time. Example are ketamine, midazolam. Now the first drug is propofol. It is the most commonly drug used in anesthesia nowadays. It is a 2,6-diisopropyl phenol. It is come under the preparation of 1 or 2% aqueous emulsion. And have anybody seen the color of this propofol? It is milky white. The tiny fat droplets in suspension, hence the white color is there. Okay. It is highly lipid soluble. It contains 10% soybean oil, 1.2% egg lecithin, and 2.25% glycerol. The emulsion is an excellent medium for bacterial growth because egg is there, bacteria can grow there, so that EDTA or sodium benzoate are added to impede bacterial growth. Propofol causes pain on injection because of this lipid emulsion. Okay, so that there are two new preparation of propofol. First is propofol lipido. It is a preparation of propofol containing both long and medium chain triglyceride in 1:1 ratio. It decreases the pain on injection. And the second new propofol is phosphopropofol. It is a water soluble methyl phosphorylated product of propofol. Okay. It does not cause pain on injection, but slow onset of action is there in comparison to old propofol. Coming to physiological and pharmacokinetic properties, PK is 11, volume of distribution 4.6 liter per kg, clearance 25 ml per kg per minute, protein binding is 98%, it is not water soluble, and pH is 7 to 8.5%. How does it act propofol? It activates the chloride channels of GABA receptor, thus enhancing inhibitory synaptic transmission, and it also inhibits NMDA subtypes of glutamate receptor. Okay. The onset of action is 1 hour brain circulation time, that is 15 to 20 seconds. And the duration of action is 3 to 5 minutes when given intravenously. Half-life is alpha half-life and beta half-life. Can anybody tell what the difference between alpha half-life and beta half-life? What do you mean by alpha half-life and beta half-life? Anybody know about this? Yes or no? Please tell. Alpha half-life, it occurs because of redistribution of drug. As I told you, there is one arm brain circulation time. Okay, so that the drug is redistributed in the brain, and this half-life is called the alpha half-life. And the beta half-life, when the drug goes into the kidney, liver, and it's excreted from the body. That means the beta half-life, it is for the elimination half-life. Alpha half-life for redistribution and beta half-life for elimination. Okay, so propofol have a alpha half-life of 3 to 5 minutes and beta half-life of 20 to 50 minutes. What is context sensitive half-life? It is a half-life when the drug is given in infusion. Okay, the concentration of drug to become half after it is being given as infusion. Approximate 10 minutes when infused for less than 3 hours and less than 40 minutes when infused for up to 8 hours. How does propofol eliminate from the body? It is metabolized by conjugation of glucuronide and sulfate by liver. It also undergoes extrahepatic metabolism in kidney and lungs. What are the effects on the body of propofol? It causes dose-dependent depression of CNS. Endpoint of induction is loss of response to verbal commands. Can be used as anticonvulsant. It reduces cerebral metabolic rate. It decreases the cerebral blood flow through autoregulation. It decreases the ICP. It can cause some involuntary movements during induction. It causes hypotension due to peripheral vasodilation. The fall in blood pressure is dose dependent and is most marked in elderly and stroke patient. This can be minimized by slow injection. In respiratory system, it causes transient apnea. It obtains the airway reflex as well. In GIT, propofol has antiemetic properties. The uses, dose and routes. The induction of anesthesia dose is 2 to 2.5 mg per kg in adults and 2.5 to 3 mg per kg in children. For maintenance of anesthesia, 50 to 150 mics per kg per minute. For conscious sedation, 50 to 75 mics per kg per minute. And for sole anesthetic, for short procedures in cardioversion, it can be used. It is very useful in daycare anesthesia and surgery. It is useful in patients susceptible to malignant hyperthermia. It can be used as anticonvulsant. It can also be used in TIVA. A plasma concentration of 2.5 to 8 mics per ml is required for TIVA. This can be achieved as follows: 1 mg per kg bolus, followed by 10 mg per kg per hour for 10 minutes, then 8 mg per kg per hour for next 10 minutes, and after that 6 mg per kg per hour. And this expect to increase the plasma concentration to 3 mics per ml. Sedation of critically ill patient in ICU. In ICU, infusion can be given of propofol like 1 to 3 mg per kg per hour. It can also be used as antibiotic and antiemetic. It is safe in patients who are susceptible to porphyrias. What are the side effects of propofol? It can cause hypotension because of vasodilation. It can cause allergic reaction because it contains egg lecithin protein. It causes pain on injection, which can be reduced by lignocaine injection. And it should not be given in patient who are hypovolemic because it causes hypotension. And as it contains eggs, it is susceptible to growth of microorganisms. Tubings and unused propofol injectable emulsion should be discarded after 12 hours. It can cause involuntary epileptiform movements. There is a term propofol infusion syndrome. Okay, what is propofol infusion syndrome? It occurs due to prolonged infusion in small children and infants, usually when used in excess of 4 mg per kg per hour for more than 48 hours. It interferes with the mitochondrial mechanism, and it can cause metabolic acidosis, hyperkalemia, rhabdomyolysis, renal failure, hepatomegaly, cardiac failure, and hyperlipidemia. Suppose if it develops, then we should go for cardiorespiratory support and go for hemodialysis. The second drug is barbiturates. It can be broadly classified as thiobarbiturates and oxybarbiturates. In thiobarbiturates, at C2 carbon there is sulfur. Examples are thiopenton, thiamyl, and in oxybarbiturate at C2 carbon there is oxygen. Example is methoxyethyl. Thiopentone, it is a racemic mixture of S and R enantiomer, and it is water soluble because it contains sodium carbonate to maintain the alkyl pH of 10 to 11. As it contains sodium carbonate, the solution is very alkaline and it can damage the tissue if injected in artery. It can precipitate of drugs that are weak bases. If you mix vacunium and thiopentone, they can precipitate. This is the vial of thiopentone. It is an ultra short-acting barbiturate. It is available as hygroscopic. It is a pale yellow powder. Ampoules commonly contain 500 mg of sodium thiopentone plus 6% sodium carbonate in an inert atmosphere of nitrogen to prevent precipitation of insoluble acid form of barbiturate by atmosphere CO2. And in OTs, we should reconstitute it with mixing with 20 ml of water. The final dilution is 2.5% solution. That means 25 milligram per ml with a pH of 10.8. The alkaline solution is bacteriostatic and safe to keep. It is for 48 hours. And how does it act thiopentone? It is mainly through the interaction with inhibitory neurotransmitter by GABA and CNS. The GABA A receptor has 5 glycoprotein subunits. It activates the GABA A receptor, increase in transmembrane chloride, channel conduction, and hyperpolarization of postsynaptic neurons. The final is functional inhibition of postsynaptic neurons of GABA type. It should always be given by intravenous route. It can be given through rectal route for sedation, but the absorption is very erratic. The dose of induction and anesthesia is 4 to 5 mg per kg in adults, but children require slight higher doses, 5 to 6 mg per kg, because of larger volume of distribution in children. What are the uses of thiopentone apart from anesthesia? It can be used in status epilepticus, a single bolus of 3 to 5 mg per kg to treat an episode of convulsion. In status epilepticus should be used, which is refractory to conventional treatment. The drug of choice of status epilepticus is lorazepam. Okay, but if the seizures are refractory, not maintained by the benzodiazepine, we can use the thiopentone sodium. The other use is it is used for the cerebral protection. The bolus of 3 mg per kg followed by infusion to protect the ischemic brain in neurosurgical patients. The onset of action is again 15 to 20 seconds. Alpha half-life 10 minutes, beta half-life 45 minutes. Elimination by the liver and excrete by the kidney. The clearance is 3.4 ml per kg per minute, and the volume of distribution 2.5 liter per kg. Thiopentone, sorry, it follows the, if you will give repeated doses of thiopentone, okay, then it follows the zero oral kinetics. That means a constant amount of drug is being eliminated per minute time irrespective of the plasma concentration. Some drugs are metabolized by the first order of kinetic. That means the constant fraction of drug is eliminated per unit time and depending on the plasma concentration. And zero order kinetics occurs when the metabolic pathway becomes saturated, leading to accumulation of the active drug and delayed delivery. Mainly the thiopentone, it follows the first order kinetic, but if you will give repeated bolus of thiopentone, it can follow the zero order kinetics. What are the effects on the body of thiopentone? In CNS, dose dependent CNS depression. The endpoint of induction is loss of eyelash reflex. It decreases the CMR2 and CBF, thereby decreasing the ICP. It is a potent anti-convulsant. It is an anti-analgesic. It decreases the threshold to pain. In CVS, it causes hypotension due to peripheral visualization. It causes increase in heart rate because of due to hypotension. There is increase in heart rate. It is called the baroreceptor reflex. Higher doses have negative inotropic effect and should be used with caution in hypovolemia in ILD patient. In respiratory system, it causes transient apnea. It produces a dose-dependent decrease in both tidal volume and minute ventilation. The medullary center ventilator response to both hypoxia and hypercapnia are reduced. It may not obtain airway reflex well, hence unsuitable for use while inserting LMA. There can be stamen release, which can precipitate bronchospasm. What are the adverse effects of thiopentone? As I told you, the pH is very high, 10.8. If you if by accident it is injected in artery, then it can cause severe spasm of the artery, and therefore it must be avoided. Suppose it happens, then what to do? We should stop the further injection, but keep cannula in place. Inject saline into the cannula and flush it. Inject through some same cannula preservative-free lignocaine or piperacillin, or you can give also heparin also. And if all these measures fail, then we should use stellate ganglion block or brachial plexus block to achieve sympatholysis if intense pain and if the tissue perfusion is jeopardy. Other side effects are it is contraindicated in patient with porphyria. Why? Because it stimulates the mitochondrial enzyme alpha aminolevinic acid reductase. It is a rate-limiting enzyme in the porphyrin biosynthesis and can exacerbate the acute intermittent porphyria. What are the manifestations of porphyria? There can be abdominal pain, psychotic symptoms like hysteria, motor neuropathies, CNS symptoms like seizures, mental status change, cortical blindness, and coma. Other effects are it can cause allergy in some patients. Extravasation of thiopentone at IV site can cause local tissue destruction. Thiopentone can be used safely in cesarean delivery, but bolus doses greater than 8 mg per kg can cause neonatal depression due to placental transfer of the drug. Coming to third drug, that is etomidate. Etomidate, it is a carboxylated immunogenol ester. It is a weak base and poorly water soluble. It is formulated as a hyperosmotic solution in 35% propylene glycol. It is prepared as pharmacologically active R isomer. It is available as lipid emulsion at a concentration of 2 mg per ml. One thing to be noticed, both propofol and etomidate, they both have white color. It can also cause pain on injection because there is a high rate of phlebitis in postoperative period. It activates the chloride channel of GABA receptor. Sorry. Enhancing inhibitory synaptic transmission. The onset of action is again one-arm brain circulation, duration 3 to 5 minutes. The dose of etomidate is 0.2 to 0.4 mg per kg IV. What are the effects on body? It causes dose-dependent depression of CNS, can produce involuntary movement during induction, but recovery is very rapid due to redistribution. It is IV agent with least cardiovascular depression and only a small reduction in BP and heart rate, very cardiostable. It can be used in shock, elderly, and cardiovascular compromised patient. One question usually come in your PG exam, which is the most cardiostable in IV induction agent. The answer is etomidate. Okay. The other effects on body are respiratory system, transient apnea can occur with induction dose. It can cause cough or hiccups, hence not ideal for insertion of supraglottic airway device like LMA. In GIT, it can cause incidence of nausea and vomiting. It metabolized by the hepatic and plasma esterase to yield inactive motor metabolites. Excretion is predominantly urinary and the elimination half-life is 1 to 5 hours. Side effect of etomidate, it can cause pain on injection and thermophlebitis. Recovery is frequently unpleasant and accompanied by the nausea and vomiting. This is one more MCQ for you. How does etomidate cause the adrenocortical suppression, which is the enzyme? The answer is 11-beta hydroxylase. Etomidate, it inhibits the 11-beta hydroxylase, an enzyme important in adrenal steroid production, and a single induction dose, it blocks the normal stress-induced increase in adrenal cortisol production for 4 to 8 hours and up to 24 hours in elderly and debilitated patients. Continuous infusion of etomidate for sedation critical patient has been shown no increased mortality, and there is no increase in mortality has been identified following a single dose during induction of anesthesia. The fourth drug is ketamine. The full name is ketamine hydrochloride. It is a phenylcyclidine derivative. It produces dissociative anesthesia. What is the dissociative anesthesia? It is a dissociation between the thalamocortical and limbic system. Dissociative anesthesia, it resembles the cataleptic state in which the eyes remain open with a slow nystagmic gaze. It is available in vials which contain 10 mg per ml or 50 mg per ml concentration. It can also be used in spinal or epidural for central nervous cell block, but it should be preservative-free ketamine for using this. What is the structure activity relationship? Presence of asymmetric carbon atoms results in existence of two optical isomers like ketamine S or ketamine R. The most frequently used preparation of ketamine is racemic mixture of, that means it contains both S and R. But for anesthesia, the S ketamine is used frequently because it causes more intense analgesia, more rapid metabolism and thus more rapid recovery, causes less salivation and lower incidence of emergence reactions. The preservative used with ketamine is benzethium chloride. These are the two structures of R-ketamine or S-ketamine. The R-ketamine causes more hallucination and S-ketamine is used more anesthesia. Mechanism of action, as you all know, you have read in your pharmacology classes, it inhibits the NMDA receptor. What is NMDA? N-methyl deasparated, which have been activated by the glutamate and excitatory neurotransmitter. It also inhibits serotonin and muscarinic receptors. It is an agonist of new type of opioid receptor. The onset of action is 30 to 60 seconds when given IV and 5 minutes when given intramuscularly and 25 to 45 minutes when given orally. Duration of action is 10 to 15 minutes when given IV. Now coming to doses and routes. For induction of anesthesia, we should use 1 to 2 mg per kg of dose. There is a peculiar advantage of ketamine. What are these? Because of it has bronchodilatory action, we can use it in patient with bronchial asthma. It maintains the systemic vascular resistance so that we can use it in tactology of failure. And as it causes hypertension, not hypertension. All other induction agent causes hypertension, but ketamine causes hypertension. So that we can use it in hypovolemic patient. So that if a question came in your PPG exam, what is the induction agent of choice in shock patient? The answer is ketamine. For analgesia, the dose is 0.52 mg per kg bolus followed by infusion 3 mics per kg per minute. For pre-medication, intramuscularly 3 to 5 mg per kg. For nasal, it can 3 to 6 mg per kg and orally 3 to 10 mg per kg. As a bronchodilator, it can be used in treatment of status asthmatic in the dose of 30 to 40 mics per kg per minute. It can be used as a sole anesthetic for short procedure like it can be used with nitric oxide in 50 to 45 mics per kg per minute. If you are not using nitric oxide, the dose is increased 30 to 90 mics per kg per minute. The points to remember with the use of ketamine, it can cause hallucinations and increased secretion. Okay, it can cause increased secretion. Hence, ketamine administration should be preceded by the benzodiazepine to decrease the hallucination, like midazolam, or antiserotonin like glycopyrrolate. Effects on the body. In CNS, as I told you, it can cause dissociative anesthesia, which resembles a cataleptic state. It causes functional and electrophysiological dissociation of thalamocortical system and limbic system. Normally, thalamocortical system is depressed. It depresses all the responses, and limbic system it is a excitatory system. Okay. So what does ketamine do? It causes dissociation between these two systems. That's why it causes dissociative anesthesia. It produces intense analgesia and amnesia as the sensory impulses from the body do not reach the cortex. It increases CMR2. CMR2 is cerebral metabolic rate of oxygen of brain, cerebral blood flow, and thereby increase the intracranial pressure. And it can increase the intraocular pressure. It increases all kind of pressure. Blood pressure, intraocular pressure, intracranial pressure, and gastric pressure. It increases all the pressures. In CVS, there is dual effect. It can cause hypertension and tachycardia by indirect stimulation of the sympathetic system by causing release of catecholamines. In larger doses, a patient with depressed sympathetic system, it can cause hypotension due to direct myocardial depression. In respiratory system, as I told you before, it is a very, very good bronchodilator. So that we are using in patient with asthma. It but does not obtain the airway reflex well. In GIT, it increases the secretion, especially salivary and bronchial. What is the adverse effect of ketamine? As I told you before, it can cause hallucinations, also called emergent reactions. These occur due to ketamine-induced depression of auditory and visual nuclei, leading to misperception or misinterpretation of auditory and visual stimuli. It can increase the tone of muscle in the body. It can cause muscle rigidity. It can cause hypertension and all type of it increase all type of pressures like intracranial pressure, intergastric pressure, intraocular pressure, and cause tachycardia. Coming to last drug, benzodiazepine. The example are midazolam, lorazepam, diazepam. Midazolam, the full name is midazolam hydrochloride. It is a water-soluble benzodiazepine with an imidazole ring in its structure that accounts for stability in aqueous solution and rapid metabolism. The solubility of midazolam is very peculiar. It is pH dependent. Okay, you should remember this. If the pH is low, 3.5, around 3.5, the imidazole ring is open and it becomes water soluble. Okay. But as the pH increases and pH reaches around the body pH, the imidazole ring closes and it becomes lipid insoluble. As I told you in my first or second slide, the lipid soluble drugs are very, very rapid in their onset. So the action is very, very fast. It is available in 5 ml vials containing 1 mg per ml ampoules or 5 mg per ml ampoules. And it does not cause pain on injection. There is a term called tautomerism. Okay. As you can see in this diagram, if the pH is less than 6. Okay. pH is less, it can convert into water soluble. Okay, in ampule which contain midazolam, it is water soluble. But when the pH is greater than 6, okay, like in our body, it converts into lipid soluble. You can see this. This is the imidazole ring, and this conversion between two, the opening and closing of ring, or you can say the water soluble and lipid soluble of midazolam, it is called the tautomerism. This is a term tautomerism. It can also come used in MCQ in PG entrance exam. How does the midazolam act? It by activation of the chloride channels of GABA receptor by enhancing the inhibitory synaptic transmission. The onset of action is 30 to 60 seconds and the duration of action is 1 hour when given IV. It is eliminated by the liver by hydroxylation and conjugation, and the metabolite is hydroxymidazolam, which has no clinical significant side effect. The uses, dose and route. The induction of anesthesia is 0.1 to 0.2 milligram per kg intravenously. It is commonly used to supplement to regional anesthesia for sedation. It can also use for pre-medication. Midazolam is given in dose of 0.5 milligram per kg orally, up to a maximum dose of 10 milligram to easily separate children from parents. This is usually possible in 15 to 30 minutes. If you are posting an OT, you can see the children are crying. They cannot want to go inside the OT. That time, that midazolam is very useful. You can give it in your syrup, the sweetened syrup, okay, in containing of like apple and orange flavor, and the child become very calm, and you can take the child inside the operation theater and proceed for anesthesia injection of surgery. It is a popular drug for sedating critically ill patient in ICU as it is cardiostable. It is most frequently used drug for ICU sedation and also used as an anticonvulsant. Effects on the body, it is causes dose-dependent depression of CNS. It is relatively cardiostable. It does not affect the heart rate and blood pressure much. In respiratory system, it does not produce change in respiration at usual dose. But caution should be taken in patient with hypovolemia because it can cause hypotension. If you have remember your pharmacology, the antagonist of benzodiazepine is flumazenil. It is a competitive benzodiazepine antagonist. It is available in vials containing 0.1 milligram per ml. It is usually given in 100 mics boluses. The onset is in 2 minutes and the duration about 1 hour. The side effect is nausea, vomiting, agitation and seizures. Okay, that's all from my side. You can ask any question and query from my any query or doubt. Most welcome. हेलो बोलूं हाँ मैं हूँ मैं अभी क्लास ले रहा था एमबीबीएस की खत्म हो गई है आता हूँ अभी क्या मैं आता हूँ अभी ना मैं आता हूँ सारी बात करता हूँ ओके